The professional ideas and opinions expressed in this podcast are mine and do not reflect those of any current or past employers. Nathan Bays, welcome to the Make It So podcast. I'm Robert Groves, and I'll be your host for this podcast. I want to start, Nathan, if we can, by just maybe giving us a brief introduction about who you are and where you've been, if you will, and what you're focused on now in healthcare.
Well, first of all, Dr. Groves, thanks so much for having me as a guest on your podcast. You've been a great friend and colleague for a long time, and I'm excited about this podcast, and I'm excited about having a conversation with you today. I'll be relatively brief with my introduction, and then if you want me to go deeper or there are items you'd like to kind of go further with, we can do that. But if you go all the way back, I grew up in Tennessee, in East Tennessee, a small town called Johnson City. College, law school, graduated law school from Wake Forest, University of North Carolina in 2007. I was 24 years old, kind of went straight from undergrad to law school. Would not recommend that, although it worked for me. But having a year or two, in hindsight, having a year or two between might have been a good experience. But I didn't really, like any young attorney, I was going to do corporate M&A work and didn't really have any indication or sense of being involved in healthcare. Started my first job in fall of 2007. Much of the corporate and M&A work slowed down or stopped in 2008 with the financial crisis. And what I found, though, was that healthcare continued to plug right through. So I found myself doing, a fair amount of healthcare work. And in growing up, my mom was a nurse, through my childhood. And then as my sister and I grew up, she kind of continued to be a nurse, but more kind of leadership, administrative type of jobs and such. But, it was really interesting and developed, fortunate to have great friends and mentors and a great network. And as part of that, one of those was an individual named Gary Bisbee, who also was a friend of yours. Gary, passed away several years ago, but Gary was a very successful healthcare entrepreneur, executive, investor, educator, was on the faculty at Yale up until when he passed. And Gary had started the business in the late 1990s with partners called the Health Management Academy, which was a small convening organization really focused on, educating, the leaders of large health systems. And in the late 90s, these health systems were, just starting to form and come together. And between the late 90s, when Gary had started that business with partners, and in 2010, Gary had ran several other companies, a small, private company, a publicly traded healthcare technology company. He sat on several public and private boards. So it had a pretty varied career. And his partners, ran that business, including a woman named Sherry Jones. And in 2010, the Affordable Care Act passed. Gary thought there was a great opportunity to come back and partner and be more involved in that business day to day and to really take that business and grow it to the next level. And so that's when I joined him in January 2011 as his chief of staff and general counsel for the business and responsibility for building out kind of a policy advisory, business there. And I was 28 and it was a great run. It was really I'd been doing healthcare transactional regulatory, work at a law firm, but it was really my introduction to, kind of the holistic aspect of healthcare services and healthcare delivery, hospitals, health systems, physicians, post-acute, healthcare technology, the whole spectrum. And it was just for me at that time in my life and journey, it was just a great opportunity. We had a lot of fun. The business grew a lot. Very successful business even today. That business, Gary and his partners sold that business in 2018 to Welsh, Carson, Anderson, Stowe, who's done a great job with that business. The current leadership team that Welsh brought in has continued to grow the business and just really done a tremendous job with it. But I through a story I won't share with you and your audience, I ended up, as that was beginning to happen, I moved to Wall Street and actually spent 8 years doing hospital health system M&A. The first couple of years with Cain Brothers, the next 6 years at Citi, leading teams doing hospital health system M&A work, in the U.S., large not-for-profit systems, also investor-owned hospitals, health systems in the United States, and some other healthcare services, and facilities as well. And then also some work in Western Europe as well, which sounds a lot better than it was, or sounds maybe more exciting than it was. But we did have, get a few things done there. And then, a year and a half or so ago, left and set up my own firm, really to marry kind of the background that I've worked. We have a small advisory business. I have a small team that works, where we work with CEOs, C-suites, boards of large hospitals and health systems with strategic advisory and targeted M&A, but also to spend time, investing, particularly in early stage healthcare technology services and growth companies, is something I started, doing over a decade ago. And I got really involved kind of in the early stage, healthcare startup community, and have done close to 20 of those investments. I sit on a number of boards of companies, some of which have, like early stage companies, grown, and some of which have not. And, some have been fun rides and others have been less fun, but you learn a lot from all of them. And it's really exciting to be around entrepreneurs, clinicians who want to change healthcare and change it for the better. And so that's been, my background and my career in 4 or 5 minutes.
Well, that's a great introduction, Nathan. And I should point out that you and I met when I was a fellow at the Health Management Academy, sponsored by Banner Health back in, I think it was 2013 or thereabouts. So shortly after you joined. And I still remember your legislative updates were some of the best parts of that program. And I was impressed by you from the very start. And so we've stayed in touch over the years. I, I have lots of questions because yours is a unique perspective at the intersection of technology and healthcare. And I know, what we're trying to figure out. I think what all of us are trying to figure out is what is the right place for technology in healthcare that brings an ROI and not just an additional expense. How do the two mesh together, and where do we go from here so that the long-term vision of better health, better care, happier providers, all of those things that all of us agree we want to happen. How do we make it so? That's the question. And so I'll have lots of questions. We'll dig a little bit deeper on each of those, but thank you for that introduction.
Yeah, of course. Well, hopefully it wasn't too long and I didn't put your audience to sleep with the introduction.
No, I don't think so. I don't think so. It's, as always, a pleasure to get to talk to you again and get to dig in a little bit on what you're thinking and how you see the world evolving now. It is a rich time, I guess I could say, in healthcare. There's a lot going on. I think the first thing I'd like to ask you about is you've been in this space for a while now, and formally and informally, you're an investor. You make bets on companies. And so I guess the first thing I'd like to ask is, how do you decide which companies you think are likely, obviously, to succeed, since you're putting your money where your mouth is? What do you look for in a company today?
Yeah, well, it's a great question, and I would say, I probably I look inward, first, Dr. Groves. What I mean by that is, I like to be involved with companies that meet a couple of different criteria. One, I like to do things that are, and my investing has been in healthcare, predominantly, and that's where my career has been, in and around healthcare on the delivery side, not on the science or the molecule part of healthcare, but on really kind of the delivery, called healthcare services, healthcare technology. But I like to look at areas where I feel like I have a level of competence. And so if there are things that I don't know well or understand, I exclude those first. So in some ways, there's a bit of kind of an inversion. It's what are you not going to do before deciding what you are going to do. And I was a decent chemistry and physics student in high school and college, but I'm not that's not my forte. So I've always stayed away from doing things that were, anything around kind of drug discovery, medical device, things of that nature. So I really stay in the sweet spot of healthcare services and technology, where I feel like I have both domain expertise and relationships, and that really pivots to kind of the next piece, which is, I like to be around things and involved in things where I feel like there's a chance that I can be helpful in moving the needle for a company. That may not always be the case, but you want
Right.
to be in a position where you can be helpful and you can be helpful in a way that's part of your normal flow, as part of the normal people you're talking with, interacting with. It's not stressful or doesn't take a lot of energy. It's a very natural way to be helpful. So I start looking at it through those lens. And then I think when it comes to the company, I would say that it's largely about um, the people. And it's a bit
Right.
of a bit of a cliche answer, but when you do, I've done a lot of early stage investing, but the reality is I've also done some larger and later things. And when you think about, you know, um, investing, you particularly with the early stage stuff, but again, really across the continuum, understanding, the person, who they are as a person, what they're trying to achieve, what they're trying to build, from a business perspective. And is it somebody that you want, to support and be behind as an entrepreneur or founder? There are lots of ways to make money, and a lot of times, good people do well in business and creating businesses that solve problems. That's great, but not always, as we know. There are a lot of people that aren't great people that do well in business. That's fine, but you have to, for me, it's about the people, and are these people you want to be involved with, and you want to support, you want to help, you want to spend time with. In this, that kind of second piece of that on the people side is are they actually trying to solve a problem and build a business? I mean, there's a number of folks that I have run across who I think are doing just great work at solving problems. And I think that's admirable. I think in many circumstances, not all, but in many circumstances, you know, you can, if you're trying to solve a problem in a way that doesn't result in kind of creating a business or something that can be lasting, there may be better venues or other venues to solve that problem. Doesn't always happen. And, we live through these periods. We're living through one right now where, there are, AI labs that are really just doing groundbreaking technical discovery work on AI. They don't have revenue
Right.
models. They don't,
Yeah.
and they're being acquired for very meaningful sums of money. So we live through these times of where, capital flows to innovation without the ability to convert that innovation to a business model in the near term. We live through those times, but I think for me, and I can't say that I've never done anything in that space, but I largely haven't. I've largely been focused on kind of capital flowing to innovation solving problems that is being manifested in a way that can become a sustainable ongoing business. And with that vision from day one, not necessarily something that would fall into 5 or 10 years down the road after maybe you do a lot of really good science and research and discovery work.
Right, right. I wonder if that's a great answer, and I hear some recurring themes there, and others I've
Yeah.
talked to, and it always comes down to people and teams at some level. That's so critically important. Alignment of your mission with theirs. Those themes are recurrent. I wonder if you can make it a little bit more concrete for us. Can you describe some of the businesses that you're talking about and what they do? You can name names if you want to, you don't have to, but I just to make it a little bit more concrete for the audience. When you say I'm interested in healthcare delivery services and I'm interested in the teams that put them, can you give us some specific examples of that?
Of course, I'd be happy to. And I think about um, let me give you kind of a couple of different examples of different ends of the spectrum, but both success stories. one of the first investments I did um, a decade ago was with an entrepreneur, a woman that I had met as she was getting ready to go through, maybe she'd even started the Y Combinator program, but she had a
Mm.
background in global health and had worked at McKinsey, and she was looking to solve some of the problems around physician reporting of quality data. And basically
Ah.
all of this stuff, we were in, if you recall back to that time, you'll know this, Dr. Groves, as a physician executive, but I don't know your audience, some may or may not, but that was right after the MACRA legislation been passed that set up the Medicare Incentive Payment Program, the MIPS
Yeah.
program, and the alternative payment models. There was a lot of quality reporting. It had gotten done away with kind of this old thing called the SGR, Sustainable Growth Rate, and put in this new structure. There was a lot of emphasis at that time on enabling physicians and clinicians with technology tools that would help them with patients, but would also send that data back to governments, back to health plans, insurance companies, and back to, large provider entities. And so there was a lot going on in that space. And she had this kind of vision of creating a business, and her co-founder had a vision of creating a business that would enable a software business that would enable physicians to report that information more easily and would allow health plans and others to receive that information in a way that was actionable. And just a tremendous person. And that business, I think, as she built that business over time, realized, or she realized and her co-founder realized that, it was not going to be, this multi-billion dollar, kind of publicly traded, business,
Right.
but she was solving a real problem, and she was having, it was a really interesting business model. She started as direct to physician, so you literally had kind of,
Mm.
physicians, just small practice physicians signing up. She pivoted to an enterprise model, and where she was, her software was being purchased by large provider organizations and large, actually in several places, health plans purchased and actually gave that software to certain
Ah.
physician
Yeah.
segments. And they were able to do
Hmm.
that, from a compliance standpoint, but they effectively allowed them to do that and report back. And successful company. That company was sold to Health Catalyst, which at the time was a public company in February of 2020. But she grew the company. It was a great outcome for her and her co-founder. It was a great outcome for the investors. But it was very much taking this, there's a problem, and how can we solve this problem? But do it in a way where you do it through business. You take capital, you take capital formation, build something, sell it, et cetera. And it was a very good outcome. The company was, I don't know, can't even recall if I said it, but called Able Health. But that was just a really good example. But it started with, just a tremendous, two co-founders, and Rachel Katz, who was the CEO, I got to know really well, and is still a friend today that
Yeah.
do
Yeah.
stuff with. And but just tremendous high quality people who were really focused on, doing something, solving a problem, but doing it via a business. And
Gotcha.
had a good outcome. But that one was, let's call it small. I mean, it was a good company, successful outcome, but it was small. It was not a large
Right.
outcome. I mean, the company was very capital efficient, didn't raise a lot of money, was sold for a nice price, but not some exorbitant price. But
Right.
relative to the capital it raised, it was a very efficient, business. Um, and then I juxtapose that with the company that I've been involved with now for, I guess, probably 8 years, a company called Unite Us, where I also sit on the board, which took, a very big swing at using technology and some services, but mostly technology, to work in the area of, social care and, non-healthcare, determinants of, or non,
Huh.
kind of clinical determinants of healthcare outcomes.
Right.
And, that business, started by, two co-founders who had military backgrounds, who were really, kind of doing a lot of this ad hoc, along with many of their former military colleagues, of, connecting former service members with mental health services and other types of social services. And, Dr. Groves has a problem. Who can we put him in touch with? And just kind of originally came up with the idea, along with several, I shouldn't say originally, there were several companies that were doing great work in this space and still are today. But they said we should use technology to solve this problem at scale, as opposed to playing telephone or, let me
Right.
email or text you and help solve this problem at scale. And, that company grew very quickly and raised a lot of capital and is scaled to many hundreds, of employees and working in all 50, US states, and has its technology deployed. But, that's one which also started with the people solving a problem,
Right.
using kind of capital formation and business organization to solve that problem. But had very much kind of a different market and took a different swing, right? And again, that business has also raised a meaningful amount of capital. We have employees in different locations geographically. It's a bit, it's not a, I wouldn't call it a big business, but it is a bigger business when you have, many hundreds of employees. You're doing business in all
Yep. Oh,
50
yeah.
states. And so they all look different, but it really kind of starts with those people that are looking to use, kind of business as a means to solve a problem in the market.
That's a great way of making it concrete for us, Nathan. And as you were speaking, I started thinking, the policy landscape has changed dramatically under Trump too. I mean, there's a very different set of problems now that we're being presented with. Do you see new opportunities there? I mean, what are the give us an overview of the policy landscape, what it means to delivery systems today, and where those problems are now that you need smart people to jump in there and start to figure out how to solve.
Yeah, well, that's a lot. That's a big question with a lot to
Yeah.
I don't know if we have enough time to answer that question, but we'll try. But first, I'll just, not to bury the lead, I'll start, Dr. Groves, with, you know, is there opportunity? Of course. I mean, depending on whose metric you believe, healthcare is, 20 or 22% or 23% of GDP, that there's opportunity, right? I mean, the reality is it's a huge component of, from a financial standpoint, and that's obviously GDP, but GDP also means it's a huge component of just our lives, how we live
Yes.
every day, where we're interacting, the decisions we're making, interactions with kind of the healthcare ecosystem. You can look at that GDP number and say, well, that's a financial number, one out of $5, maybe slightly more spent, but it also correlates with time, right?
Okay.
Individuals in this country spend a lot of time with the healthcare system, more as they age, but they spend a
Yes.
lot of time interacting with the system. And so, um, the policy landscape has shifted, and it will always shift. The thing about healthcare is when you are that meaningful of a component of the GDP, and when the origin dollar for so much of healthcare is a government origin dollar via the Medicare and Medicaid programs, you, you're in the political game always, and that
Yeah.
there will never be. I know this,
And more than half the dollars now come from the federal government to
from the
fund
federal government.
healthcare.
Yeah,
Yeah.
close to
Yeah.
60%. Yeah, and
Yeah.
so, there's this dynamic. I think some, you know aspire to be in a time or in a place when the government, doesn't have as heavy of a hand in healthcare. And, call me a pessimist or an optimist or realist, depending on whether you think that's good or bad. The government, healthcare is politics.
Yeah.
When the government is that involved in your business, it will never be, healthcare will not go back to a free market, dynamic, and the government dollars will not come out of healthcare. So, the policy landscape will change, and you have different people that are in charge, in this country at the federal level, at state levels, who make decisions. And so being flexible and being fluid in that policy is important. But I think there are a few, kind of key themes that run through that are foundational. And then I think there are a couple of key themes that are, emerging, or places where I think are, places to spend, time, and where there's kind of a lot of action on. But I think, the foundational themes are, the rate of growth for healthcare spending is needs to slow. And I don't know that it's very much, you know, bipartisan or nonpartisan, however you feel about that. But whether, Democrats, or the Democratic Party are in charge federally, or Republicans, what you see are, both parties pulling levers in different ways, around, spending growth. And I think we value in this country, my take is that, in this country, ultimately, you know, at least historically, I don't know about the future, but things kind of land where they're supposed to land. Meaning if people, are really, really upset with something and don't like it, it generally changes over time, not immediately, And so there's a lot of complaint around the dollars that are being spent in healthcare. But I think the reality is it's easy to talk about that. It's a great talking point politically. At the individual level, people have friction with the system, but also in this country, our country values the healthcare system we have. And I think they like aspects of it. They like that, the ability to have access in a way that you don't have access in other countries. And I think that comes with a cost and comes with a price. People like the ability to be able to go into the ED, and whether you have insurance, you have to be treated. And I think that societally, that's something in this country we value, and that comes with a cost, right? And then you go down the list. I'm not saying those are the main drivers of cost for your listeners. I'm just giving examples of, right, these are things that we value, and these are things that are probably not going to change. But the rate of growth has to slow, right? And I think you're seeing that. You've seen it really starting, we referenced earlier in this conversation, just, what Macro did and some of that. You've seen it, starting in the last presidential administration with the changes to Medicare Advantage, which have been carried through in this administration. You've even seen it at a much more nuanced level, or you saw it at a much more nuanced level 3 or 4 years ago when, inflation was running, very high in this country, and you saw, Medicare, inpatient, outpatient physician fee schedule increases, Medicaid rates at the state level that were increasing a lot less than inflation, right? And
Right.
that's a way, if inflation is 6% and your rates go up 4%, in essence, the dollars that are coming to you in a real term are going down, right? And so
Yes.
I think you see, so I think it is you'll see, continued pressure along the rate of growth. I think, the percentage of GDP we spend in this country on healthcare is going to continue to grow, but it has to grow slower. And along with a number of different areas, just the fiscal situation of the federal government and the fiscal situation in many states would suggest that the rate of growth has to slow. And I think you're
Well,
going to continue to see pressure on that.
yeah, Nathan, let me unpack that a little bit because there's only a couple of ways to do that, right? I mean, uh, you either slow the advancement of or do you? I'm not sure about this, but you either slow the advancement of technology to some extent because new technology is expensive to develop, and
Yeah,
people can argue about that. New drugs are expensive to develop. There's a
yeah,
complex regulatory system through
yeah,
which they have to
yeah,
go and perform to certain standards, and or you can look at one of the comparisons that's often made and I have trouble every time somebody says, well, look at Sweden or look at, this other country, because we're so different in so many different ways from other countries. But, or you can start to ratchet down what, caregivers make. You can ratchet down what hospitals make. And of course, the hospitals are looking at that and saying, look, we're operating on low single digit margins.
right.
A 4% error means we lose, $1 billion or whatever that number is. So how do you see that actually happening? How does that growth slow? And what's the what's the blowback from those pressures that we're seeing mount externally. And the other topic that's part of that is how attractive is a career in healthcare now for those who actually deliver the care, if in fact autonomy and pay continue to ratchet down.
Yeah, well, it's a great question. So I'll probably kick the second one back to you, although I'll give an answer. But as a physician, you're probably closer to that than I am. But I do think that it is, I think that probably most of the items you just mentioned, Dr. Groves, or the actions you just mentioned, lower compensation for caregivers, hospitals. I both agree and disagree, because what I think it will be is, I don't actually think it will be lower. I just think that the rate of growth will slow. And I think it is slowing, right? And I think it will continue to slow. And so I think that ultimately does result in pressures, results in financial pressures, because you have entities that are built, on an operating chassis expecting X, and they're going to get Y. And Y, and that's at an entity level. That's also at an individual level. And it doesn't mean that it's going to go down. It just means that you're expecting to go up, right? And it's not going to go up as much, right? And if you think about, again, your career as a physician, I'm sure you had expectations of, here's where I'm starting out of medical school. Here's where I think I'll be in 10 years. And here's where I think I'll be in 25 years. And I think that, my view is that for anyone coming out of medical school today, they'll have those same expectations, but the 10-year and the 25-year, financially, they may end up lower than their expectations. I don't think it's going to be,
yeah.
I don't think their compensation is going down. I just think that the rate of growth is going to have meaningful compression.
Yeah. It's to respond to your counter question, Nathan. It's really interesting, because when I went into medicine, I didn't really think all that much about, what I was going to make and what that meant. I was very fortunate in that I went to an in-state school that was inexpensive. I had some help from my parents. I didn't graduate with hundreds of thousands in educational debt. So I didn't have to worry so much about, gosh, I need to go into dermatology so I can pay this off. And so I was able to pursue what I really wanted to pursue. And I think for a lot of physicians, historically anyway, healthcare is not about the business side. It's more about the job of taking care of patients, and just being free to be able to do that in the way that we believe is the right way to do it. So part of me thinks that the change in, when I was a kid, my dad was a family practice, or they didn't call him family practice. He was a general practitioner. Yeah. He didn't make buku bucks. I mean, he made a decent living. He was able to take care of his family. But of course, the thoracic surgeons, many of them owned jets. I mean, that was quite the role at that point in time. And those days are gone.
Right.
And part of me thinks that's a good thing. That people ought to go into medicine because they really love what they do, not because they see it as a vehicle to become wealthy. On the other hand, there are a tremendous number of sacrifices that individuals make, and some of those I didn't have to make in order to get to the point of being able to practice medicine. And so I don't want to take away from that. And so it's a balance, really. And I guess when I hear people say, would you still recommend that somebody go into the practice of medicine? My answer is absolutely. If that's what if that's what gets their juices going, I would absolutely recommend it. And the world's going to change again. Nothing stays the same. But I'm curious about maybe you could give us an overview of that policy landscape today and what it means for different aspects of the healthcare system, and maybe even what it means for investments going
Yeah,
forward.
be happy to. I'll have one comment just in response to what you just shared, and then I'll pivot to that. I think what's happened over probably the course of your career, and you see this is the reduced, you know, ability to generate outsized compensation as physicians, and the increased regulatory burden, which is real, right? And I
Yes,
think
it
that
is.
that ties back to, I think, a dollar of government, expenditure results in, the old joke, 10 pages of regulation, right? And the reality is, but the more involved the government comes as a financier, as the financing mechanism for healthcare, the more they're going to want to have a say around how those dollars are spent. And you've
Yep.
lived that through your career.
Yep.
They weren't 60% of the healthcare dollar when you started your career. They are now. So their role, financing healthcare has increased, and as it has increased, it has also resulted in additional regulatory, you know, um, burden, quite frankly, for those who are providing care. But what that actually does is that drives the economics and power from the individual to the entity. And you've seen
Yep.
that, because it's much harder to be an independent practice physician now than it is to work as an employed physician at a health system, or to work at an employed physician at a health plan or a subsidiary of the health plan.
Huge shift over
It's,
my career. The
it's
vast majority of docs are employed by larger entities now,
Yeah, and
not in
that's
private
not,
practice.
and there's, and this is not, I'm not criticizing that at all. But what I am saying is that these trends kind of go hand in hand. The way the economics
Gotcha.
move actually drives also the practice dynamics, because if you think about that piece, as you've dealt with, compression, no more cardiac thoracic surgeons with jets, they're working in the health system. What you end up doing is you shift economics, and the power shifts from the individual to the entity, right? And so the
Yes.
the entities are now the place where you get your compensation. They have say around how you practice. And again, in no way at all am I suggesting that's a bad thing, but it is the transition that has happened. And I would posture it's largely, not exclusively, but it's largely been driven by economics.
Yeah, yeah, I absolutely agree with that. And it's not, I mean, one of the problems that we've had in healthcare for some time, as you well know, is the huge variation in practice.
Right.
And that is a direct result of lightly regulated, my dad would cringe if he heard me say that, private practice as it has been historically.
Right.
That is a direct result of that. Yes, you've got great autonomy. Yes, you can do things the way you want to, and everybody did things a little bit differently. And as Brent James is fond of saying, that means that everybody cannot possibly be getting the best care because there's
Right.
just too much variation. So I agree with you. It's not a bad thing. It's tough for docs who, my dad was used to going in on rounds and writing a couple of sentences in the chart and,
Yeah.
having a nice conversation with his patients. And and it's not to say there weren't pressures then. There certainly were, but it was a very different role than it is today, where you're literally not only part of a team, but part of a much larger organization. And therefore, you kind of got to dance to the tune that that organization is playing to some extent, not sell out your principles or your mission,
No.
but there are constraints today in the practice that didn't exist then. And that's not, as you said, necessarily a bad thing, because as we get better and better at understanding what best practice is, it's much easier to implement that across a body of physicians from an institutional perspective.
Yeah, certainly at scale. Um, so, just to pivot to your question about policy, I mean, I think there are a couple of things that are happening now, worth taking note at. I think the first one is, there's a kind of a whole reset around, the value-based care space from a government perspective. You had the Affordable Care Act was passed, in 2010, and a lot of energy around alternative payment models and acronyms that
Yeah.
some of your audience would know. Some of them may be too young to even know these acronyms, but that certainly has tapered. I think there's still great work that's occurring out of CMS and out of the Center for Medicare and Medicaid Innovation. I mean, a very strong team there now that is continuing to push through, kind of non, up the middle, fee for service payment models. But I do think there's a bit of a reset going on in that space. A lot of what has been tested and tried over the last 15 plus year has not generated meaningful savings, certainly in excess of the additional overhead and administrative costs to organize and set up those models. So there's a major fundamental shift going on with that, and I'm optimistic that there'll be, that it's actually one of the things I'm very optimistic about in this administration. I do think there's kind of a fresh look at that, and my view of that is those will always be things that happen, around the margins. I don't think they'll ever, be, kind of across the board. I know many people may, disagree with that, but I do think even if they happen across at the margins or in certain areas and they work, it's great for patients, right? And it can some of the aspect about these models is there's a financial piece which is important. But there's another piece that there are better ways to actually organize around care delivery that result in better outcomes for patients, whether those be clinical outcomes or just psychological, emotional outcomes as to how they're being treated. And that matters as well, right? It's not just the financial piece. And so I'm optimistic about that. I think there's very much a restructuring that's occurring around, government insurance. And I think, there's been a lot that's happened. The pandemic, people came on to the Medicaid rolls. Now people are coming off of the Medicaid rolls again, even before this administration with redetermination, but certainly with the One Big Beautiful Bill Act last year, there will be, work requirements, other aspects. You have a lot of attention on Medicare Advantage, what many people, again, in both parties think were kind of, excess profit pools that were created by gaming certain, revenue enhancement.
I happen to agree with that.
And so there's a reset. So I think that reset, we're in that reset right now. That reset is happening in the government insurance business. And so, both Medicare Advantage, Medicaid managed care, how those are funded. It's also happening with how government dollars are flowing directly to providers, whether those are through state, directed payment programs, supplemental payment programs. So you're going through, a pretty meaningful shift around, kind of government insurance financing and government provider financing. And so there's a lot of action that's happening around that, that space. And then, what I think is probably the most interesting area of all is just kind of the continued growth of, the specialty pharmacy, and then even to the next level, cell and gene therapies, which, are very, very expensive, but have the potential to be curative in nature. So that's the aspiration of these, therapies as they're being developed. And so to me, that whole space has become so interesting over the last 10 plus years, and I think will continue to be interesting. And that is both a policy piece, but also a marketplace, dynamic that's occurring as well.
Yeah, well, I could talk to you all day, Nathan, and there's so many other topics I'd love to cover. You'll have to come back, but one of the questions that we ask, the name of the podcast is Make It So, and what we mean by that is how do we make it so that we change the trajectory that we're on now? And maybe you've already unpacked that in the reset that you've talked about. But let me ask you, if you could do one thing to help right the ship, and we've got increasing costs, decreasing access, still a huge variation in care across entities and across cities. If you had a lever and you could do one thing, where would you put your money? What would that be? What problem do you think would be paramount to solve to help make it so?
You know, um, that's a tough question. Um,
Yes.
it's a tough question. If it was just one, um, you know, I think if it was just, well, let me give you, if can I make it two?
Yes. Yeah.
Okay.
You've got
We may have to come
permission.
back and edit this because then I'll be like it may be three or four. But
Yeah.
but I'll tell you what I'll give you two. Um,
Okay.
and so if you think about, and I'll be, succinct, but if you think about, there's a lot of attention, around, you know, changing behavior, changing health behavior. How can we do this? I think that's very hard. I think that's an entire, I mean, and that's a very complex, and there's a lot that goes into that.
Yeah.
But I think that if there was a structure, so one of the things that, occurred in the One Big Beautiful Bill Act is there were a couple of investors that really advocated for this idea to create these what are now called Trump accounts, and to basically, when children are born, to seed an account for them with $1,000 and put it into, a stock index fund to
Right.
grow. And I don't know what, we can unpack this more, but I think it would be, I think doing something similar for children when they're born around healthcare would also, I don't, it could be financial money into a health savings account, which we talked about, which could help alleviate some of the financial burdens of healthcare. It could be something around, kind of literacy or education, or, kind of a, once you turn, 6, you're going to have some type of, formal interaction with the healthcare system, another one at 12, or something that just is helpful in kind of promoting, in the same way that, those savings accounts are intended to help, children, particularly children, who may not otherwise be exposed to financial literacy, to the benefits of saving, to step in and do that, but do it in a way that is not, at least for now, is not really government meddling, meaning it's we'll seed it and then we're gone, right?
Yeah.
As
Yeah.
something similar that you could do for kids instead of trying to change behavior of people when they're 50, 7, and, you as a physician, you have a patient and they have a heart attack and they have a stent, and then they're eating, fried chicken 3 meals a day. I love fried chicken too, but, 3 meals a day the next day, because it's really hard at that point to start changing behavior. But if you could start doing
True.
things at a young age that would both incentivize behavior and also might incentivize, or at least have some degree of buffer for some of the financial burden that healthcare can provide, I think that would be one that I think could be meaningful. And then I think the second would be, you mentioned this word access, and I think that, the biggest complaint that most people have, in my view, you may disagree, about, the healthcare system is access. When something happens, how do we know where to go, know who to see, ensure we're getting the right care? And I don't think government can solve that problem. I'm not even sure, the market can fully solve that problem. But I think, you know, um, there has to be more that can be done than the way things are being done today.
Yeah, no, those are two very creative and great points, Nathan. And I'm reminded of another thing that I learned many years ago from Brent James, and have a lot of respect for his knowledge. And he said, dollar for dollar, investing in education improves population health more than investing directly in healthcare, which is a fascinating concept and aligns perfectly with what you were talking about earlier. So maybe there's something there, and maybe there's an administration that is interested in listening to creative solutions like that. So thank you for that. I love that idea. I think we're going to wrap it up here. This is a
Yeah.
great place to stop. Thank you so much for your time, Nathan. It's been a pleasure talking to you.
It's always a pleasure and always just an honor to be on your podcast, Dr. Groves, and hopefully you'll have me back at some time. We can chat again.
Absolutely. Until next
Yeah.
time, Nathan.
Sounds good. Thanks.